So we're thrilled to be presenting the results of our phase 2 study of the combination of Isatuximab, which is a monoclonal CD38 antibody, in combination with Carfilzomib, Lenalidomide, and Dexamethasone. This is being used in newly diagnosed patients of all risk, so standard and high risk, multiple myeloma. The unique aspect of this study is we're using once-weekly Carfilzomib, and in addition to that, for maintenance, we're stratifying based on risk. So patients who have high-risk cytogenetics, which we include deletion 17, 1q, duplication, 414, 1416, and 1420, will all either receive the triplet combination versus those without high-risk features that will be treated with lenalidomide alone. So what's really been interesting and wonderful to see is, so all patients received 4 cycles of the quadruplet. Patients who wanted to have transplant could receive transplant, although of the cohort of 50, only 5 patients chose that option. The majority actually chose to receive a total of 8 cycles of the 4-drug regimen. And so when we pooled together the results of all the patients, whether they received transplant followed by 2 cycles of consolidation versus 8 cycles of the 4-drug regimen, we saw an overall response rate of 100% and very high rates of both VGPR better and MRD negativity in excess of 70%. So I think one of the hard things that we deal with as clinicians is what is the optimal way to manage patients who have features that may suggest they may have poorer outcomes. And so for this trial, we elected to have an upfront strategy where patients who had high-risk cytogenetic features received more aggressive therapy, a triplet versus the single agent of lenalidomide alone. And I do believe that's the right way to go. We're seeing, prolonged, we now have 2 years of follow-up, and what we're seeing is the overall survival is 95%, and that the progression-free survival is in excess of 90% as well. So I think this risk-adapted strategy is a really important one that can be applied to the real world as well.